Hi, my name is Emily. I'm the social media coordinator for Atlas Psychiatry. I'm here today with Dr. Nicholas Pejic. Today we're going to be asking questions from the waiting room. These are going to be questions that patients may be hesitant to ask their psychiatrist. So we asked several people throughout the state about their questions, and we'll get started with question number one. Ready?
Yep.
All right. So Caitlin C. from Waterbury, Connecticut, she asks, I'm scared to fire my psychiatrist. How do I break up with them?
Breaking up with one psychiatrist? Well, I understand the fear because patients are they're dependent on medications. And I will do second or third or fourth opinions sometimes for folks, and they'll tell me why they left their psychiatrist. A lot of times it's because the doctor was not asking them how they were doing and making adjustments accordingly. They kind of kept them on the same medication. And so if someone's still symptomatic, meaning like their rating scales for their depression or anxiety are too high, then the doctor should be trying to make some changes. And I think part of the reason that happens is in psychiatry, we have a lot of treatment resistant patients. And so you kind of just get used to having someone at a certain level, and you might stop trying to get them better if you don't have tools to get them better. So, for example, like we do ketamine therapy at our office, we do transcranial magnetic stimulation, EMDR, we have therapies for all kinds of things. But that's at our clinic. At other clinics, if you just have a solo doctor, if they don't have it, they're not going to present it to you all the time. So if you are a patient and you're thinking of breaking up with your psychiatrist, you would probably want to address the reason with the psychiatrist and say, listen, I don't feel like I'm getting the results, or I've been wanting to make changes here. I'm thinking about getting a second opinion. And any professional doctor or professional psychiatrist acting professionally should say, okay, sure, like you should get this second opinion and come back to see me if you want, or let me know how it goes, and then have a plan for who's going to manage the medication. I've had some patients where they might see me a couple times and kind of interview me and get to know my style and what I could offer them as a second opinion. And then they'll tell their other psychiatrist, hey, I'm going to do some specialized treatment with Dr. Pejic. And sometimes they'll come and see me and we'll kind of tune them up. And then they'll go back to the other doctor. Because a lot of times folks like their psychiatrist, they just don't feel like they're like getting well enough. In a nutshell, I would talk to the doctor, say you're thinking about a second opinion. Two, you may want to present to the doctor your rating scales. There's two important ones, I think. That's a PHQ-9, that's Patient Health Questionnaire number 9. You can Google it. And if your number is above a 10 on that, then you should like present that to your doctor. The second one is a GAD-7, number 7, and you can Google that. And if that one's above like a 7 or so, you can do things to treat the anxiety. And also remember, like, patients are customers. They don't have to do everything their psychiatrist says for them to do. They don't have to take the medication that they're taking. Now, this is not me saying people should stop their medication, but as a consumer, the patient has a right to informed consent. That's to know like the medications, the side effects from the medications, the alternative treatments for the medications. And if they're not comfortable with something and the doctor doesn't have any other thing they're presenting, they may want to get a second opinion then. Lastly, if you switch to a new psychiatrist, then that clinic can ask for the records, so you don't have to actually like confront your psychiatrist. I think it's very appropriate to tell the person that you had been seeing, hey, thank you, I got a second opinion, I'm moving to this other clinic, and you don't have to explain yourself too much. I think you can simply say that and say that this other doctor is going to take over my prescribing, so that there's no two cooks in the kitchen problem. That's a long answer, but yeah, that's kind of what I think about that.
I'm going to move on to Paul L. from Erie, Pennsylvania.
Okay.
He says, I admit certain things to my psychiatrist. I worry he won't like me anymore if I tell him my deepest thoughts.
That's a good one. So what's the question there? Like, they're afraid to admit, like, should I admit these thoughts to my psychiatrist?
Basically, yeah, like if I say these things, I'm worried that, this guy won't like me anymore.
Well, you're not going to go fishing with the psychiatrist or something, this professional relationship. And we're trained to help people through difficult things. And I think when patients tell me those types of maybe shameful or guilty feelings, it helps me work with them and work through those. Like, we want to help people through those things. If someone's having guilt, it means that they may have done something that was like breaking some rule. And if they unburden themselves by sharing that with the doctor, they may feel better. Beyond that, when patients have shameful feelings, it's usually because they feel defective or they feel broken or something. That's indicative of depression often, or like some kind of abuse, low self-esteem. So we want to help with that as well. And I think the treatment needs to be collaborative and where you reach that level of trust. Now, in terms of being liked or not, there's some patients might be unsavory. They may say things that irk me. I've had patients say disparaging things about different classes of people, for example. And I don't like that. And I'll tell them, hey, don't talk like that in my office. That doesn't fly here. But that's very rare. And it would really take a lot for me to like dislike somebody. I think the hardest patients, the ones I personally don't like, is where they're not telling me the meat of the matter. They're kind of like telling me like where they, I don't know, superficial stuff rather than kind of getting there. But that for a patient to kind of get deep with you, they have to develop trust with you. And we know that. So my advice to somebody is just to tell their psychiatrist, hey, there's things that I would want to talk about, but I'm afraid you won't like me, and see what the psychiatrist says.
Okay.
Yeah.
I think that's good advice.
Yeah, it's a good question.
Megan E. from Tampa, Florida. If I talk about suicide, will I be hospitalized?
The answer for that is maybe. But I tell my patients that they're paying me to keep them out of the hospital a lot. And what I mean by that is they're paying for a service for expert care. And the type of care we render here is often care that they don't have in hospitals, like ketamine therapy, transcranial magnetic stimulation, trauma therapy. Some of those therapies take weeks to do. And if you're locked in a hospital, you can't do them, right? It's kind of an ironic thing. Also, being hospitalized can be traumatic for patients, some people, especially if they don't go willingly and they're taken against their will, and like their civil liberties are taken away from them. So I don't casually ever hospitalize anybody. Usually, if someone tells me I'm having suicidal thinking, they're not hospitalized. Like, I work with them and discuss with them like what they mean by suicidal thinking. How frequently are they having the thoughts? What's the intensity of the thought? That kind of tells us like how high risk somebody might be. And if somebody's willing to work with us and come back to our clinic and take the medications if they need meds, or do therapy, and there's not a plan, like an action plan for them to harm themselves actually, then I won't hospitalize them. Patients can go to the hospital voluntarily though, at any time. So sometimes they know they need to go to protect themselves, and that's okay. They should do that if they're feeling that at risk. And then sometimes I'll have to do I'll have to hospitalize somebody against their will, but it's usually because they're not eating or drinking enough, or they're not thinking logically, to where they may really do some harm to themselves. That's tricky though. I mean, we like to be conservative, and but I certainly don't want to traumatize a patient And usually folks coming to us, they want help. So they know something's wrong and they want to participate in that. And that makes it easier to stay out of the hospital because there's some recourse. You can make a safety plan for them and a treatment plan.
Yeah, okay. So Shayla from Scottsdale, Arizona wants to know, can I ask you what you're writing?
Oh, you mean in the progress notes, like
Yeah.
writing?
So during the session, what are you writing?
Usually it's pretty straightforward. They actually there's legislation that's been passed by the government where patients have access to their records or more easily have access to their records. And because doctors know that now, we tend to write more collaboratively, where if a patient were to read my notes, that they would say, oh, they find it validating. Like my doctor listened to me, he wrote down what we discussed and what the plan is. He wrote down my symptoms, that type of thing. So I might say, so-and-so returns after a month from seeing me, they're doing very well. They found that the dose increase to 20 milligrams of Prozac was helpful, and they're no longer having the chronic worry and the difficult time controlling the worry. They're sleeping better through the night. I usually say that we reviewed the medication list and we reviewed their medical history, and then some other things. But it's not like I'm daydreaming and doing a psychodynamic formulation and writing like a term paper on there. It's pretty straightforward.
Well, I mean, that just goes to the next question. Lance Carr from Kansas City, Kansas, to know if you zone out while he's talking. Like
occasionally, yeah. Sometimes, actually, in therapy, like when I was being trained in therapy, we learned this where if you're if the psychiatrist is daydreaming, sometimes you daydream about things that are related to the patient. So the daydreaming can kind of help you understand or the content of what they're talking about a little bit. For example, if the patient's talking about something and I start daydreaming about something grief related, whether it's in my life or otherwise, the patient kind of brings you to that space so you understand what they're going through a little bit better. Mm-hmm. Alternatively, sometimes if I'm daydreaming, it's because somebody is not discussing anything that is of primary interest for the session. Like they're speaking too many superficialities. They're not going deep emotionally with what's going on in their life. It's like kind of surface level. So when you have someone that is kind of like that, you sometimes one might daydream, and that gives you insight into what that patient might experience in their day-to-day life. If they're saying things that are not engaging people, or they're not being real with people, then they may not have deeper relationships, and then maybe that's a portal to why they have problems in their lives. So it's not always the case that happens, but yeah, we're human, and sometimes we will daydream. But usually I'm really quick to bring it back, and I usually then think like, oh, why is my mind, wandering off?
All right. Well,
I will say,
what? Go on.
Oh, I will say that it's pretty intensive. A lot of times when we're sitting, thinking, and listening, we are actively listening, and there's a lot of things I'm checking off in my mind while I'm talking to somebody that they'll never know, but I need to do it as part of our work. For example, if someone's talking to me and they're telling me their symptoms, in my mind I'm thinking of all the classes of medications, when they took them, what past side effects they had, what medications could we use going forward, how do I get this person all the way well, and then which medicines to present to them, and then like which medication will this patient push back and say, I don't want to take it, or yeah, I will try that one. So there's daydreaming, but then there's the majority of what we do is very very much active listening and doing the work. Sorry, I'm talking too much.
No,
Are you
that's where
daydreaming?
Me? Nope. All right. Well, that's really
right.
all I've got.
Those
I'll
are great.
have some questions for you, but
Okay, good.
for now,
We'll
let's
keep it going.
just go back to work.
Thank you, Emily.
No problem. Bye.
Okay.